الشكر الجزيل لسعادة الأستاذ الدكتور بروفيسور الأستاذ طه، ونتمنى يعني أن نراه دائما بكامل صحته وعافيته. ويعني نحن مهما قدمنا من شكر ووفاء جميل لهذا الأستاذ لا يمكن نوفيه، ونتمنى أن يعني ندعو له بطول العمر والصحة والعافية. المحاضرة حقيقة محاضرة يعني cannot يعني no one can do more than that. يعني أنا I cannot talk about the excellence of this lecture. ويعني أنا أعتقد إنه بروفيسور طه بينا طواف يعني ما في الدرماتولوجية لكن في الهيستوري اوف درماتولوجي، في الهيستوري اوف ميديسين، how to يعني to be an excellent medical practitioner. وده طبعا الآن يعني كل الأدفانسز الحاصلة is towards excellence. فإحنا نتمنى إنه يعني أبنائنا الشباب يأخذوا بهذه التوصيات اللي هي knowledge, skills and attitude and to master these skills. يعني الآن احنا حنبدأ إن شاء الله المحاضرات المقررة. والفيرست ليكتشر
Recording in progress.
نتكلم عن role of trichoschopy in dermatology. ويعني trichoschopy واحدة من السكيلز which is needed to improve the practice in dermatology. الدكتورة أهلا وسهلا. ريم طبعا تفضل دكتور ريم.
بسم الله الرحمن الرحيم. My dear boss, colleagues, attendants, and followers, السلام عليكم ورحمة الله. I'm Reem. I'm Dr.Reem Dafa, registrar at Dafa Hospital, batch 42. On behalf of myself, I would like to present my topic, which is about role of trichoschopy diagnosing, scarring, and alopecia. By definition, trichoschopy is the dermatoscopy of hair and scalp and allow better recognition of morphological structure not visible to naked eyes. Advantage, it is non-invasive, quick, cost-effective office technique. This is image for trichoschopy, as we see. The term trichoschopy, instead of dermatoscopy of hair and scalp, is described by Poland dermatologist Adriana Robeska, which is applied in 2006. This is image for her, Adriana Robeska. We will talk about types of trichoschopy. We have two types, handheld dermatoscopy, which stem for magnification. About subtypes, we have non-polarized, which is allow excellent visualization of superficial skin from epidermis to dermo-epidermal junction, which is required immersion fluid like alcohol, aqueous, and oil. The second subtype, polarized, which is minimized glare and allow better visualization of underlying structure from dermo-epidermal junction to the superficial dermis, which is more deep, and use polarized light to cancel out reflection from stratum cornea. The third one, which is hybrid combination of contact and non-contact lenses. This is image, as we seen here, for hand hair. This one. The second type, which is digital video dermatoscopy system, which is allowed to 20 to 200 fold magnification and higher. We have also two subtypes, which is follicoscope and USB connection-based device that are equipped with software that allow assessment of hair shaft and thickness using trichoschopy image. And the subtype other trichoscan, which analyze hair growth in consecutive trichoschopy image. This is video trichoscopy, like this. We have to comment about some structure when we're doing trichoscopy and about better. It allows for magnification observation of the filament. We'll comment about hair shaft, hair follicle, which is dots, and perifollicular epidermis and blood vessel. Abnormalities in the appearance of these four structural components of the scalp aid in the differential diagnosis of hair loss. Firstly, we will comment about normal trichoscopy finding. We have mean hair thickness more than 0.053 millimeter in the frontal area, more than 0.050 millimeter in the other temporal and occipital. Percentage of thin hair less than 10% in the frontal and occipital area and less than 13% in the temporal area. The percentage of the spinocebaceous unit will with single hair less than 35% in frontal and 30% in occipital and 40% in the temporal area. The fourth one, there is normally yellow dots less than 4 in field vision with 70-fold magnification in frontal area and only 1 in the other. Perifollicular discoloration lower than 25 in frontal, lower than 15 in occipital and 20 in temporal area. We have normally pinpoint blood vessel in frontal area more than 80% of patients and thin or rising blood vessel in occipital and temporal area. We will comment about certain disease trichoscopy findings. Firstly, we will start with lichen planopilaris, which is primary lymphocytic cicatricial alopecia with different clinical pattern hair loss, which is common cause of other primary scarring alopecia, hence broad alopecia. We have 3 parts of lichen planopilaris. Firstly, classic lichen planopilaris, frontal fibrosing alopecia, and Graham-Little syndrome. About finding, we have 2 stages, active and inactive stage. About active stage, we have perifollicular scaling, scale from forming tubular structure over proximal portion of emitting hair shaft, called tubular perifollicular hyperkeratosis. As shown here, this is perifollicular scale, and also here one. This will comment firstly for active stage. Secondly, hair cast, small white tubular keratin structure that completely wrap the hair shaft, characteristic but not pathognomic. And so this is hair cast here and here. Also, there is round perifollicular blue-gray or violaceous area targeted better pigment, which is indicate pigment incontinence with dark skin phototype. Here, this is perifollicular gray or violaceous area. Also, we have elongated linear blood vessel close to hair follicle forming a V shape with hair shaft. here. This is with blood vessel here. This is hair shaft and the blood vessel here forming V shape. This is all about active stage cell. We see inactive lesion. We have white dots, fibrotic, irregular shape, large, flattened, follicular opening. Here, this is white, fibrotic finding, which indicate inactive lesion. Strawberry ice cream butter, white dots tend to become confluent to form either white or milk red areas, like here, white and red, which give ice cream like butter. This is in active stage. These findings are non-specific and may be observed in other type of folliculocentric scarring alopecia. So, secondly, we will discuss discoid lupus erythematosus. It is chronic cutaneous lupus erythematosus, type of primary lymphocytic cicatricial alopecia, and responsible for 50 to 89% of cases of cutaneous lupus erythematosus. This is a picture of discoid lupus skin, cheek, lips, and hair, as we see here, and this is wood, and this is just a sign of the ear. About trichoscopy finding in DLE, also we have active and inactive stage. About active stage, we have large yellow dots, follicular keratotic plug, larger and darker, which is yellow than dots seen in alopecia areata and androgenic alopecia, as seen here. And we have thick arborizing blood vessels, commonly are present in peripheral lesion, indistinguishable from these seen in basal cell carcinoma, and there is fine interfollicular scarring. We have scattered dark brown discoloration of the skin, which give dirty appearance and indicate pigment incontinence. Follicular dot or follicular red dots corresponding in histopathology to dilated blood vessel and extravasated erythrocyte. And we have blue-gray dots also forming speckled pattern on dark skin and supposed skin. About inactive stage, we have red spider yellow dots, which is larger and radial than arborizing emerging from it, highly characteristic of late pre-fibrotic stage. We have structureless milky red or white areas, and finally we have lack of follicular opening. This is yellow dots and red dots and uprising blood vessels. Here there is large yellow dots, and here follicular plugging here, and there is uprising blood vessels here. The third one of primary lymphocytic cicatricial alopecia is central centrifugal cicatricial alopecia, which is slow progressive symmetric cicatricial and center on the crown or vertex. Clinical feature begin and remain most severe on crown and vertex or skull, gradually expanding in central centrifugal fashion. As shown here, trichoscopy finding, there is no specific trichoscopy finding for cicatricial alopecia. Trichoscopy finding very similar to those seen in traction and lichen planopilaris, traction alopecia. Absence of follicular ostia, follicular scarring, pinpoint dots, and villus hair. Overall feature, there is very pillar white gray halo found in 94% of patients, and highly sensitive for central centrifugal cicatricial alopecia. Non-specific finding here: white scale, pinpoint bleeding, and villus hair. Lastly, we speak about folliculitis decalvans, which is neutrophilic cicatricial alopecia, The term decurvus derived from Latin decurva, which is mean remove hair. Trichoschopy finding, also we have active and inactive state. Firstly, we have tufted hair, most frequent finding. We have more 5 or more hair emerging from single follicular unit at base of hair tuft, surrounded by band of yellow tubular skirt, scalar formation for the anterior epidermal hyperplasia, star bear sign, and yellow follicular pustule, and visual, there is no specific vascular adhesion. Late inactive stage, we have fold of epidermal hyperplasia, milky and red-white area lacking follicular opening. This is star perseverance. This is star bears, which is more than 5 hair emerging from hair opening. Normally, we have about 2 to 3 only one, and here is more. This is star bear sign. Here we have tubular scaling and compound follicle and linear fibrotic band and strawberry red color. Thanks for attention.
Recording stopped.